Good morning, everyone. I want to thank Dr. Peacock for his insight into the mind of an emergency room physician, something that's always been interesting. And I think the observation is that, patients that come in with dyspnea get admitted. And so our healthcare system has had a lot of interest in using ReDS in the emergency department. Here are my disclosures. And why the emergency room? Well, when we look at patients that get hospitalized in our hospital with congestive heart failure, the point of entry for 75% is the emergency room. And we've asked the questions, are there avoidable admissions? When we look at length of stay in our patients who are admitted with heart failure, 39% have a length of stay of less than or equal to 3 days. We believe that these are patients that have really minimal or low congestion and could potentially be treated by alternative methods. And when we kind of go back to why patients come to the emergency room with shortness of breath and get admitted, the overwhelming reason is dyspnea. But our ability to differentiate dyspnea and figure out the etiology of dyspnea is very difficult. What do we use? Well, we use the physical exam, but it's very difficult because traditional methods of symptoms and physical exam findings are either sensitive or specific, but typically not both. And they also struggle to communicate the severity of fluid or volume overload. Dan said that they're able to identify congestion in 78% of their patients. He's doing better than most. If you take a look at data from the ESCAPE registry, when they took heart failure cardiologists and looked at their ability to predict elevated filling pressures, it's barely better than the flip of a coin using either physical exam or use of pro-BNP. So, we don't have the right tools for predicting left-sided pressures and assessing congestion. And so ReDS really fills this gap where we're finally able to literally look through the wall and determine patients' lung fluid content. And what our goal was when we purchased our vests was to answer the question, is there an alternative to this pathway that we've all become very used to, which is a patient comes to the emergency room and is automatically admitted? And so what we proposed with our emergency room colleagues, and I think, one thing that Dan said that I think is really important is that the partnership with other providers is really critical for leveraging this technology. And what we propose to them is using a combination of vital signs and absolute measures of lung fluid to determine whether patients needed to be admitted or not. And what our responsibility was to the emergency room was to be a safe landing zone for patients who they were going to potentially discharge from their department. And so low-risk patients had reasonable vital signs and a ReDS reading of 25 to 35%. Moderate risk was 36 to 40%. And we did want to rapidly triage appropriately the patients with high fluid content. And so those with fluid content greater than 40% were recommended to be admitted. And we collected data on these patients, and we looked at their outcomes after 30 days. The population was patients with a history of heart failure presenting with dyspnea. This ER pathway was provided, but ultimately clinical decisions were made by ER staff based on a combination of things. And then we performed a chart review over a 6-month period to evaluate outcomes in the 30 days after the emergency room visit. The hypothesis that we were interested in is, will normal lung fluid levels allow providers to discharge patients safely from the emergency department? So this is our baseline characteristic, a typical community-based heart failure emergency room population. 222 patients, a mean age of 74.6 years, half male, half female, 50% with history of CAD, 45% with diabetes, 50% with atrial fibrillation. 45% had an ejection fraction of less than 40%, 55% had ejection fraction greater than 40%. And the mean pro-BNP in this population was quite high, 7,900. When you look at cutoffs, 82% had a pro-BNP greater than 1,000. When we looked at the patients that presented, 36% had a ReDS reading less than 35, 21% were in the yellow zone with a ReDS reading between 36 and 40, and 43% were in the red zone. So this was our total population, and what happened? Well, we'll look at outcomes based on their ReDS score alone. So this does not incorporate all the vital signs findings, but this was ReDS as an isolated value. And we look at the patients that were in the red zone. Again, you're seeing 90% of them being admitted, a very small proportion of them being discharged or admitted for non-heart failure related reasons. In the yellow zone, 70% were admitted, 15% were discharged, and 15% were non-heart failure admissions. And when you looked at patients in the green zone, only 35% were admitted for heart failure. 35% were able to be safely discharged from the emergency room, and 24 were admitted for alternative diagnoses. You know, and one thing I'll comment on is that the pro-BNP in each of these cohorts is very high. Even if you look at patients in the green zone, the mean pro-BNP was 6481. So, you know, if you take a population of 80 patients with pro-BNPs of over 6,000, and you say they came to the emergency room with shortness of breath, to discharge 35% of those patients, I think is really, really phenomenal and really interesting. And this was statistically significant, and what we concluded was that normal lung fluid content, patients were more likely to be discharged or admitted for an alternative diagnosis. I also think it's interesting that we have this 35% cohort of patients admitted with heart failure but who have no congestion by ReDS. And I think that's a really interesting patient population and creates new questions to answer about the nature of acute heart failure and the therapies that we provide to them, perhaps allowing us to target our therapies based on something other than their ICD-10 code. So what happened to the patients that were discharged? Well, we had 39 patients discharged. That's 18% of the population. So again, 20% of patients are being discharged despite having a history of heart failure and presenting with dyspnea. And we look at patients that were in the green zone. In 88% of them, they did fine in the 30 days subsequently. One was admitted, which is 4%, and one was placed on hospice for end-stage interstitial lung disease and failure to thrive. In the yellow group, there were 6 patients discharged. There was no event for 83%, and 17% where one patient had a heart failure admission. And in the red zone of 7 patients, 5 did fine in 30 days. 1 was admitted for heart failure, and 1 was admitted for a non-heart failure reason. And these are small numbers, but we hope to collect more and more data, and I think a registry is a really good idea to really understand what happens to these patients. Is it safe? And can I go to my emergency room physician and say, you know, this is a reasonable way to send patients home and to have them be managed in an ambulatory setting. This is of great interest to our accountable care organization who want to avoid unnecessary admissions as well. And so in summary, heart failure hospitalizations are common and costly, as we all know, but often quite short. Strategies for avoidance of heart failure hospitalizations is critical, particularly as we shift to value-based systems of care. Traditional methods are inefficient at identifying fluid overload, presence, absence of, and the severity of in the emergency department. Utilizations of ReDS to measure lung fluid content in the emergency room can identify a low-risk heart failure cohort with little to no fluid overload. I think this is a population that could potentially be managed very safely as an outpatient rather than inside the hospital. Thank you very much.